Welcome, everybody. On behalf of the North American Spinal Cord Injury Consortium, I'd like to welcome you to our special sponsor series where we have the opportunity and, frankly, the great opportunity to have one of our partners talk about their product, but more importantly, how their product really helps us with spinal cord injuries. And we're so excited to welcome our friends from Avazzia. And I'll introduce our speaker in a minute, but I just wanted to let you know a little bit about who we are as an organization, again, to remind some of you who may not be too familiar with the North American SCI Consortium. But our mission is to bring about unified achievements in research, care, and cure, and policy by supporting collaborative efforts across the spinal cord injury community. We achieve this mission, really by identifying gaps, communicating resources. This is something what we're doing today. And we act as a conduit of collaboration between the community of people living with spinal cord injuries and the many stakeholders. Today, we're going to talk about something that's really close to many of our hearts, and you can see in the next slide, really how one of the key things that affects people with spinal cord injuries, and it is pain. 1 in 3 people with spinal cord injuries suffer and experience chronic pain, is what we like to call central cord pain. And the estimates suggesting almost 50 to 70% of people with spinal cord injuries develop pain over time. And as you know, pain is debilitating and can significantly impact our physical and our psychological well-being. I know of many friends, brothers and sisters with spinal cord injuries that really can't function in daily living without some type of relief. And normally, and unfortunately, it's only traditionally has been through medications such as opioids. And as we know, the counter effects and the side effects of these drugs can really be debilitating, and to the point where someone can't operate any kind of motorized vehicle. They really can't get through a day. And so they're destined to be really managing this pain on their own through some type of medication. But as we are going to learn today, that is not the only way. And we are very fortunate to have partners in the community that are working hard to help people that are suffering from pain like this. So I'd like to introduce to you Avazzia, one of our latest sponsors. And as we traditionally like to do, is make sure that you get to learn about their product and what they do and how it impacts us with spinal cord injuries. And I want to introduce you today to we're very blessed to have the speaker, Dr. Dombrowski, representing Avazzia, and he'll explain in so many ways both about the background and the technology and its application to us with spinal cord injuries. His bio is very long because he's very, very distinguished, but I'll let him introduce himself today and he'll take it from there. At the end of his presentations, we'd be glad to take any questions, and he'll stick around to answer any questions from you, the audience. And feel free throughout the discussion to put questions in the chat room that we can also pose to the good doctor at the end. And if not, we will also take your mute off and let you ask direct questions directly if you want to at the end of the presentation. But from here, I want to introduce Dr. Dombrowski. Take it away. It is all yours, my friend.
All right, sir. Thank you. Well, once again, I'm an independent doctor from the company, and I've used this product not in the military, although I spent 26 years in the military, the last 10 years in the Pentagon. So I know I'm going to heaven at least 30 seconds before everybody else, because I've been to hell. But they did let me get a whole bunch of your taxpayer dollars and go out and do some device management and some other technologies. And we were able to take cadaver arms and put them on our soldiers because the arm robotics weren't working. We were able to transplant some muscles and skin. We were able to look at their traumatic brain injury and how to monitor that. And we were able to look at how to get them off of the opioids, because it's one thing to get shot, and that's painful, having been shot at several times. But what's really bad is the blast injury, how it just tears tissue and causes a lot of chronic pain. And unfortunately, it caused a lot of spinal cord injuries. So we've got an issue. I do consult with the VA, still consult with the Department of Defense, but we need to do something besides the opioids, because the folks were just having too much problems in that. So I was downrange a lot. Was back in the Pentagon doing some developmental stuff, and then I got out. And the first thing I noticed was little old ladies have a lot of pain. And that's back when we could give little old ladies about 10 Percocets a day, and their livers could handle it. The one lady, I think her liver was bigger than my car, but she could handle all those opioids. So you take them off, and then she has a lot of pain. So I was looking for a device that could block pain. Well, pain nerves are different, and I don't want to talk down to anybody, so please forgive me if I come across that way. I just blame it on the Pentagon. But the nice thing about pain nerves is that they're in a matrix. They're in kind of a lattice, if you will, a kind of a crossover, and they're non-myelinated. So it's easy to talk to them. It's easy to influence them with other signals. I got a chance to learn how to block signals from other bad people that were trying to affect bombs going off. And so we were able to do some blocking signals. And one day my back felt better. And I'm like, hey, what signal are we on? Oh, we're on this signal. And I went, okay. And it's AC versus direct current signal. And we're doing this. I'm like, wow, okay, I'll write that down. And went out looking for this kind of a signal to use. And no one's making it, because everybody's making a TENS unit, and it doesn't have enough volts to get through any tissue. It's only one signal, so your body gets used to it. And I need something for pain, and so right under my nose, literally about 20 miles away from my office here in Fort Worth, was this company. And I said, well, do you do microcurrent? Yes, we do. Do you do alternating? I said, yes, we do. It's like, oh, well, you can sit down in my office then. And then we looked at, how would you like to do 25 little old ladies that have no filters at all on their emotions, and see if we can get them better. And that's what we did. And if you get 27 little old ladies between the ages of 60 and 94 to agree on anything, you're doing really good. Probably should run for Congress. So we didn't publish it because it was just too good. We put the knee pain, we put a pad on each side, medial and lateral, and turned the thing on, and they did great. I didn't present it when the case presents, because I want to do some high-end ICU stuff. But then I noticed that, pain, whether it's from a spinal cord injury or some other injury to the nervous system, is still pain. And inflammation affects the pain nerves a lot more than we thought, certainly than I thought, 5 years ago when I started using this device. And so, all the ladies went from an average of 8.2, which was published, that part was published, down to a 4.1. And you're like, well, wait a minute, how can everybody settle out of 4? Well, because those that had more pain were just thankful, and all they did was, go to the bathroom and go to the kitchen and back, and then they were okay. But the other people who didn't have as much disease, well, they did more. They were much more active, and that's what explained how they could all come into just one particular pain perceived level. And those who weren't as active loved being more active, and then they could live on 2 Percocets a day, and then eventually just on hydrocodone, and that was really a lot of fun for what we're doing. And they all did let me know that they appreciate it, so that was good. And but since getting out of the military, we're still doing some interesting things with our veterans, especially with spinal cord injuries. But I go to the next slide, under notifications, and we always got to have those. I'm not doing this, I'm not doing that, and that's all our notifications. And so if we're on that slide, which is slide 5, then we're good to go. So okay, and then we're going to go over the 4 cases, and then we'll talk a little more about the physiology, and again, after the different cases, love to have you look at, give me some questions in here and there. These are all almost like friends of friends, because I wasn't actually out to treat a spinal cord contusion. It just happened to be one of my retired friends from the Pentagon. And so we'll go ahead and go to that first case then. So that's slide 7, case study 1, cervical spinal contusion. So he had just gotten out. He'd done very well in the military and decided, well, you know, I haven't been on my property just outside of DC where he had some apple trees, and he decided he was bored. And there's two things that you never want to have you know, a bored doctor like me or a bored retired military guy, because we cause mischief. And he went out to go trim his apple trees and fell off his ladder and landed on the posterior part of his cervical spine, right about C5 level. And then obviously, you know, presented with, you know, loss of movement, upper and lower extremities. And so what do you do when you get a spinal contusion? You give them the steroids, and it doesn't do you do much good. And then hence that's where the rest of you folks come in and do great wondrous things. He didn't really have any pain. He actually had loss of any kind of feeling. And so we wanted to put these Avazzia devices on pads on his neck above and below C5, but we wanted to put them such that they could affect the blood vessels, because we want to get more blood into the spine and remove white blood cells. And we'll kind of show you what we think is a theory on how that works. But without further ado, if this gentleman had this injury, then we would just take regular 10 unit pads. You're like, well, why is this working so well? And it looks like I'm putting a 10 unit pad. So here's C5, we're putting it up here, both on his right, above and below, and then on his left. And we're hooking up to the device. And again, right sided device, left sided device. And the reason why we're doing that is because, again, we're trying to affect the blood vessels and the tissue edema almost more than we're trying to affect the nerves. Okay, because again, it's all about getting circulation. And the more swelling you have in the tissue, the less circulation you're going to have. So it looks like that, left and right. And that was placed on there for 3 days straight. And on day 4, he was able to get a little bit of spontaneous movement in the fingers. And then got some spontaneous movement on day 5 in the lower extremities, and regained the rest of his upper arm movement. And then 16 days later, he was able to ambulate again. The thing that kind of was interesting to me is when he would ambulate right arm, right leg, just like a 2-year-old does. He had to learn how to walk because that little part of the cerebellum didn't work anymore either. And when I said, hey, friend, who was a high-ranking gentleman, hey, you walk like a 2-year-old, he wasn't real happy about that, but he was walking, and a lot sooner than we thought. And we'll talk about how we think we affected the tissue. But that was the protocol. It's N of 1. We haven't had anybody else fall off their ladder and hit their chain link fence with the back of their neck lately. But there's all kind of different ways, especially in motor vehicle accidents, to have contusions to the spine. And that's what happened there. And he was able to, again, ambulate pretty soon. And about a year later, he's doing fine. He says he's got 100% back, and that's great. Okay, so let's move on to case number 2, Guillain-Barré syndrome. Well, again, this isn't much of a wartime thing, so why would I run into this? Well, my nurse, after I got out, we were doing our flu shots, and she managed to get influenza A and B at the same time. Thought that you couldn't do that, but she did. And literally got the Guillain-Barré syndrome, which is an autoimmune to the myelin sheath or the axons of the nerve, and they get destroyed. And you usually get hospitalized and sometimes on a ventilator because it'll just, it'll interrupt your diaphragm and your ability to breathe with your intercostals. But again, the usually prognosis standard is 6 to 12 months, and you may not be able to work for a good 12 months. And I needed her back. So I was able to go over to where she was doing some rehab in the hospital, place these on. And the way we did that was a little different. I'll show you why. In that, again, we wanted to do the whole spine. So what we did was we went from T1 down to L5. Here we are, right there. Yeah, that's fine, sir. And we did that right and left. Well, we found out later on that, you know, because I wasn't there all the time, when they would give fresh pads, that sometimes the techs would sometimes not keep the right and the right, but they would do bottom and top. And so you shifted the different electronic field, and that seemed to work almost better than what we originally wanted to do. And then after she got a little more core strength, then we shifted from pretty much L5. And if we spin you this way, sir, then we went right to, you know, rectus femoris, right and left L5. But once again, we're finding out that it sometimes works better to have this hooked up to one machine and this to the other. We'll talk about the different fields that are made. And it may be that, you know, on days that have odd numbers, you have right side, left side, and day with even numbers, you switch them. That may be something that's of good use, you know, from a physiology. And we'll talk about that in a second. She then went from there to, and after she got more feeling in the hip flexor, sorry, and we went ahead and then gave her 2 weeks of front to back, which is thigh and quad and hamstring. And again, generating a signal that way. But again, we've also seen it where it worked right to left quad, right to left hamstring. So, and she got better. My wife took her shopping, which was her favorite pastime when not working for me, of course. And got her there in 6 weeks back to full duty. And she wore the Avazzia just on her anterior tibs, right and left, just because she still had a little bit of drop foot when she came back to work, but otherwise was doing great. So again, those are two friends. Now a daughter of a friend of mine is she came in and had a case. If we can go to case study number 3, I really appreciate that. And that's slide number 9. The background is she was 22 years old. She was 5'2", and she weighed 328 pounds. And so she begged her mom and dad to do a bariatric surgery. And I didn't know her then. She got a pretty extensive one. It's a cousin of a Roux-en-Y, where they take and cut half the stomach, and they reroute some of the gut, but they managed to pull everything so darn tight that they actually affected the what we believe was the phrenic nerve, and pulled it up partially off the diaphragm as well as the vagus nerve, and that resulted in severe nausea. And she would vomit 10 to 12 times a day. She did lose the weight, and I don't say that in jest, because it was really miserable for her. And they came in and said, hey, we heard about this, because the mom, who's a nurse, deals with a lot of our veterans with chronic pain. And we can talk about that and just in low back pain later if you want. But again, if you've ever had any kind of diaphragm injury, again, from motor vehicle accidents and or some really interesting surgery, this did help in that we put the Avazzia pads right at T5 in the back, because again, nerve into your stomach would be T5, and then we put them right in front here. Yeah, right in front here and here, right off the attachment, off the diaphragm front, just about a centimeter below the actual 7th rib here, and we're able to put signals back and forth. And again, that helped decrease the signal. So you're like, well, wait a minute, why do you want to decrease any signals? We're spinal cord injuries. We want to augment signals, and I think that you get a balance of signal, the right ones. And so, you know, some of the spinal cord injuries with the chronic pain is they've got the motor and the sensory nerves, but they still leave the pain nerves. And so that's why you may want to add this technology here and there for your folks. Now, again, we got her just vomiting once a day, and her pain decreased significantly, and she still can't eat a normal meal yet. And yet we can't get a surgeon to go in there because it's such a surgical mess that no surgeon wants to be a part of that suit. And so she's really not doing too good. So we're going to continue to move the pads around, but we pretty much got the success that we could get. And then she's looking at some other things right now. So we put a gastric stimulator in her stomach, and that helped quite a bit. And that's where she's able now to eat a meal. And she was going out on dates prior to this, and then was able to, we just go to the dinner with the suitor, and then she could now enjoy the meal. So that really helped her out. The last case is maybe some of the ones that are more down your alley for spinal cord injuries. Again, that wasn't really where I was trying to get to. I was just trying to, in my rehab clinic, get the grandmas off because a lot of them couldn't get their knees replaced because they had horrible COPD. They had other spinal injuries in the spinal bones themselves, and so they weren't good candidates. And so that's how I got into this. Well, once again, another nurse, friend of mine, her daughter is on slide 10 here with the transverse myelitis. You've had those cases before. Weakness, it's probably a little higher, probably like T4 to T8. Again, sudden onset. Prognosis again was told, 12 months in the hospital. You'll probably never get out of a wheelchair, and pretty negative. And I know you don't want to overpromise things. That's not right either to your patients. But man, they hung a lot of black crepe and were kind of negative. So it says, well, we've got 4 people with transverse myelitis in this medical center that's in Waco. And so I was able to go down with one of my techs, and we set this lady up, and we did the pads again bilaterally there at T8, and then again down to the spinal cord. And after 40 days of treatment, we were able to get her to sit up. So again, what we're trying to do is catch her right at what we thought was about T8, or where she had obviously lost the sensation and motor control here. And then obviously down to L5. And then after that, we then converted, at the same time, we used 2 more machines, and then we went from just above this down to the hip flexor, and then here to the hip flexor, which was essentially anterior quad, to stimulate that tract, which is both femoral nerve and sciatic nerve at that point. And then from there it went to quad, hamstring, right and left. And I left that on for about 4 days, and she stood on the 4th day. And I said, well, doc, this is placebo. You got no reason to believe that. It's like, well, but you diagnosed her on the MRI. It's a swollen tissue. You saw the amount of white blood cells on the cerebral spinal fluid. So if you think she's faking it, okay, you want to try it on these other 2 people? And they said, no, we need an IRB. And I said, okay, fine. And we got her out on a walker and on day 12, and she's been doing great ever since. So now, Doc, I think some of this stuff, is more a miracle than reality. And how come some guy who escaped the Pentagon got so smart? Well, I've never really gotten smart. I think I've just looked at capability gaps, and that was my job in the Pentagon in the last 10 years. Besides treating people at Walter Reed and a few other places. Again, if we put in these E stimulators, which seem to be interesting, they're still, again, direct current. They've still got some other issues. But if we go to slide 11, why not have this neuromodulation done directly in the epidural space, which I'm sure you're familiar with? Again, there is risk of infection, bleeding. But the main thing that I've seen is the fibrosis of that tissue, especially the glial cells around there, and other fibrotic tissue. I was involved with the DARPA arm, where we implanted a chip in the motor cortex and was able to move an arm, which was great. And then the little chip scarred in, and then it was useless. And then it lasted about 4 months, and so it was tough to call that a success, but it did help quite a bit. There's always, you know, in the words of NASA, if something can break, it will break, and so there's hardware complications. And again, if there's something wrong, they have to remove it, put it back in, redo the scar. It's a definite impact on their lifestyle. The other thing is, well, you know, in Texas, it can get a little bit warm, and if you have these pads all the time, the problem with the pads is they can create some dermatitis. And so we've come across pads that are made of silicone, and you just attach them with paper tape, however you like. And if you like a semicircle or larger or small pads, you know, they work just fine as well. And they're not from China, but they are from a little island real close to that, and you can figure out where that geography is. And again, the thing that you have to be concerned about on just about anything, including medications and medicine, is the body accommodates to it. And that's where this device is on like a TENS unit. And we'll go down and cover that in the next slide. And if we go down to the next slide here, and the different electronic stimulation signals. And yeah, the signal matters, and you might not be able to see it, but the left upper is just kind of a one line. And no, the patient hasn't died. That's not asystole. That's just a direct current. It's just in, it comes in, there's no frequency, it just turns on. The TENS units tend to go on and off. And so you get that sort of right upper kind of almost like a little castle square wave. Okay, and then alternating current has a sinusoidal, and sometimes people try to innovate when it comes to a square wave, and they'll do stacking. They'll stack different squares and try to get something that's different within that signal. That doesn't work. The thing with Avazzia that I haven't seen with any other companies that are out there, and I've kept looking. If you find one, please get a hold of these guys. I'm happy to take a look at it. You need the higher voltage. What's the voltage on a TENS unit? 4 volts. Okay, it's the same microamps, which is 0.001 micro versus milliamp would be 0.1 to 0.001. The volts have to be anywhere from 30 to 250. Why? Because that's the volts that you use in your own nervous system. So why not mimic what's going on? You know, if I want someone to understand me, I need to speak their language. You know, in the military, we think if we shout at somebody enough that they'll understand us. It doesn't work that way. We've proven that many times. And so if we can speak the same language, then we can influence something. I think that's what the goal of this company is to get a higher voltage. You dampen it so it becomes more sinusoidal. Okay, you round it off the curves, the squares, if you will, and you pulse it so that it has little pulses, little packets of energy that vary, and it's got little variations between the frequency and the amplitude. So it's like playing a whole song, like on when you play the radio station. If they played the same song over and over again, you wouldn't even hear it, let alone pay attention to it. And so that's why we need to change the frequency and the amplitude, which I think they've done a decent job of doing that. And the way, excuse me, then the waveform will change when the tissue changes. And so the more ability of damaged tissue to absorb either light, laser, or microcurrent is dependent on the damage. And so if it is damaged, it will absorb more, which is kind of nice because we're getting it to where it needs to be versus reflecting it. Okay, and so now let's go into the next slide, and hopefully I'm not going through this too fast or not fast enough. So again, you can't help everybody within the Pentagon. So I'll just keep on rolling here. Why are those two pads, and what kind of a micro circuit is there? What kind of electronic field is a better term? Electronic field is there between the two pads? You put them right and left, and they're flat. Do they have like a pancake kind of a? No, they don't. They actually have. It's almost like a slinky. And my grandson's got my slinky somewhere. I got one, but when I was his age, made out of metal. That thing's probably worth more than my car right now. But anyway, it comes and goes, and it goes up and down, and it arcs. Okay, it has to arc because that's the way the electrons spread within any device. And we'll talk about different modalities and how to create that field. But again, it's a microcurrent, very close to what your current is. It's 60 hertz in your outlet of your home, but it's really only about 0.5 hertz that you use within the nerves. And electrons through a nerve travel at what speed? Okay, at your next cocktail party, you might want to mention this. They travel at the speed of sound. Electrons that go through the fascia, all that gristle and covering, those electrons move almost at the speed of light, which is kind of nice. So when you step on a tack and you irritate your fascia, you'll jump out of the way before you realize, wow, that really hurt. And that's an interesting thing that the body has. And so we believe we can influence not only the nerve tissue, but some of the fascia, which in many ways gets converted to thicker scar, which it's mostly fibrocytes anyway. And so we believe we're affecting both of those tissues in a good way. So, but some people are into electrochemical stuff. So I want to pay some homage to them. So we can go to the next slide. This guy's Russian, and being Polish, I don't read a whole lot of Russian text, but anyway, they did come up with some different microcurrent applications when it comes to exercise, because they've been doing pretty good at the Olympics. And they looked at the body, and they looked at how certain frequencies can influence the effects of the bidirectional current. So that's slinky. And the better you have certain electrolytes, the better it moves, which is why when you're out of electrolytes or you're out of Gatorade, there's an effect, and there certainly is. Can we affect a lot in the mitochondria? Not sure that we can. It's certainly within the cell wall, there is some effect within the ATP. And we can sense this through indirect methods. How we know anything we've done so far? Well, there's less pain. Okay, well, that's not objective. We've used thermal cameras to increase circulation on the lower extremities with and without spinal cord injuries. We've also looked at autonomic injuries through changes in the heart rate, beat-to-beat variability. We have sensors that do that here at our clinic, and so we can document some objective data. Again, how do you objectify pain? I don't know how to do that yet, but there may be a way of looking at different sensors that can say this is more painful than other parts of the body, and we'll see where that goes. If we go to the next slide, we've done some live treatment, but what else can we use? You can create an electronic field with just about anything. Here's another device that they've used that creates more of an elliptical kind of magnetic field. It gets you to do something. It has a feedback that'll give you some impedance signals, and so that's kind of interesting. They've got some other devices that'll be coming up in just a second, and there's a feedback loop within this device that is based on if the tissue's getting better or healthier, the waveform will change. If you have the doctor's one, which is more expensive than the one you can take home as a patient. Which when you go down to the next slide, we see the one that looks kind of goldish, and that's a certain frequency, and that's got 4 frequencies. And that's what people take home if they need to do some longer therapy. If you're going to do some therapy and you want that kind of impedance / conductance as a doctor, you'd like to have this feedback, which gives you that little readout there, and that's how we know we're changing some of the tissue and the feedback. If we go back, we go to the next slide, slide 17. We've got again, it's a high. What we're talking about is a high voltage pulse microcurrent sinusoidal waveform. Okay, it's got some presets which help. Again, you know, how many radio signals are there in an FM dial? Well, there's a bunch, but there's certain ones that people like more than others, and there's a way to program that in. Again, the Avazzia can analyze some of the conductivity, which is the opposite of impedance. And so if something can conduct electricity really well, it probably is damaged. Why? Well, salt water is great at moving electricity through it. So if you've got a lot of salt water, a lot of proteins in fluid, that's edema that goes right through it. And that doesn't really help you a whole lot when it comes to showing that that's normal tissue. But maybe the damaged tissue needs it more. So that actually might be an interesting side effect of what's going on, as well as the rate of reaction, how well the tissue absorbs it, also shows some health. Got about another 3 minutes here in my book, but we'll see how to go. And then we're going to take the questions. Number 18 is some of the different modes. There's a rectangle mode that we've got on the back on slide 18 there. I showed you the Y electrode. We've got a brush mode for anxiety, and they literally comb their hair to decrease some of their anxiety. And we've looked at different anxiety scales. We used to have a little pencil that really did some of the G points, and a lot of acupuncturists use this for pain and other stimulations. And then we've got the 2x2 pads that we have for TENS units. Again, looking at how to look at impedance or conductance, we'll see these waveform pattern changes. That's on slide 19. And so we've got another feedback that we're on the right channel. Well, why don't we jump channels? And we usually do a 1 hour channel. If we're going to do a 4 hour treatment at home, we'll jump 4 channels. Every hour we'll change the channel within a certain box of frequencies, and that seems to help too. Why? I don't know. If you're looking for answers here, I might have a few. I've got a lot more questions than I have answers. And again, it looks at what's a square wave component. It's not really a square wave. It's stacked waves, and that's on slide number 20. Again, the waveform changes when the tissue changes, and you've got to have high volts. Again, TENS units can barely get to the dermis. You need stuff that goes down to the periosteum in some ways, down to the nerve roots, and that takes at least 150 volts, as I've seen it with just good old-fashioned back pain. We're looking at, is there another therapy that we could use that is additive? And we want to look at some of the ultraviolet or cold lasers, and that's a misnomer. If you've got a laser and you're putting in someone's body, they heat up. I'm a military physician, and I know what lasers can do to people, and none of it's really good unless you know exactly how to control it. So what we've found out is we're just going to have a center of excellence for neuromuscular health here in Dallas-Fort Worth. Love to have you come out sometime, take a look at what we're doing. And we're going to look at different tissues. We've already done some stuff with frog skin and how that closes with different electrical tissues. So once you get the depth right with either laser or microcurrent, you have to make sure there's no heat, and there's ways of getting that feedback. You can get increased vascular blood flow to tissue, and the way we believe we do it with the Avazzia is that the blood vessels themselves have nerves that go to them, sympathetic nerves, myelinated, and they can be affected by the Avazzia to open up small blood vessels, which is what we did in case 1, we believe, was not only did we get more blood in, but what signals white blood cells to come into a tissue, and what signals that is the low microcurrent field. So if you've got some damage, then that normal electrical field that you have in different spots of your body isn't there, and so the white blood cells come in. And so if you use an augmented field, then white blood cells leave, which is again what we do. We thought in case number one, and so increased metabolism, that we think we can get with the laser. We're just not sure yet. And we talked about the movement of white blood cells, and we think that's really exciting. When it comes to intractable pain, there's two thoughts. Is the longer you have the pads on, the better. Some people think that the longer I'm doing something with my little wand against the tissue, I'm doing something, I'm more active, or my spouse can do that. And then, that gives them a better bond, because you can get really isolated as a patient if you've got chronic pain, and people don't tend to hang out with you too much when you have chronic pain. What about, intractable pain? Well, if it's intractable, nothing helps it. That's hence the term. But if you've got some immediate post-op pain, we believe this may be helpful as well. We've used it on not only autoimmune nerves, but also on joints and tendons, specifically lupus. We've had some good luck with that, and as well as MS. Again, everybody wants to have stem cells. Everybody wants to be, 20 years old again. Not me. I didn't think 20 years old was all that great, but certainly I'd still want to be able to run up and down a flight of stairs like I used to. So we believe that if we do any kind of augmenting of stem cells or exosomes, that we believe that having this kind of augmentation of microcurrent with that would be very helpful. All right, and I got close to where I needed to be according to what my instructions were. So I'm not going to pat myself on the back, but certainly I'm ready for questions, because I used to play Stump the Dummy all the time in the Pentagon. So bring it on.
Hey, thank you, Doctor. I encourage anybody out there to please indicate whether you'd like to ask a question or not, and perhaps put your hand up in the queue, or put your hand up. Come on, and Gab will field the questions as they come in. I just have a question, Doctor. If you can go back to your case study with
Yes,
the
sir.
spinal cord injured person,
Yes, sir.
just a bit of clarification on that, and
Yeah.
would like a little bit, maybe a bit more background. Just so you know, our audience is fairly sophisticated, that we've heard a lot of things about studies over the years, and I think it's case study number 1 was the one.
Yes, sir. Yes, sir. Spinal cord contusion. Yes, sir.
That's right. How, maybe just take me back, the friend that you worked with here, how long was he injured before you applied the therapy?
Approximately 8 hours.
So we still very in the acute stages, right?
Yes, sir.
Okay. And was he feeling the pain, or this is more about function?
He really didn't have that much pain until about 4 days later. And then we treated that with a different padding system. The main thing was to try to minimize the swelling that we saw in the initial MRI. The MRI was pretty significant when it comes to the contusion and swelling. And so our main thing was to try to get blood flow to the area. And we saw that on thermal camera. So that was somewhat helpful and reassuring to the patient. We still did the standard treatment. I mean, we're not saying don't do this, just do whatever you need to do in the ICU, but consider adding this certainly in the first 3 days.
All right. And maybe this is more of a broad question towards the company itself. Obviously, these units are available in the rehab setting, and you also have units available for home use. Maybe you can walk us through how one would be trained to bring the unit home, or how it's applied to in the rehab setting itself, if you want to help us with that.
Oh yeah, sure. Again, I hate to harp on my favorite subject, which was how the Army did good things with your taxpayer dollars, but essentially we made it kind of Army medic proof, in that it's got this one happens to have 4 channels on it, the one you take home, and it's got an output that goes to the 2 pads, and that's all you get is 2 pads. We try to do 4 pads, but there wasn't enough voltage. That gets turned on. You go ahead and select one of the four, and usually I write on top which one of the four channels I want you to use. And then once you turn it on, then you go up on the voltage all the way to the very end, which is just approximately 225 volts. And then you can back down or back up depending how you're feeling and what device you're using. Normally, this is for the pads. This is, you can hook this up as well. On the back, if for some reason you forgot your pads or the wire broke, whatever, then there's also a device back here that's a positive and negative anode, cathode, and you can use that just on the surface of whatever you're treating. And so if I can't train you how to use this in 5 minutes or less, then I need to go back to train patients better. When it comes to the doc stuff, there's just a few more things when it comes to the impedance part, and that we have in a nice diagram. You can't really see it here, but again, because you have this feedback onto it, that's important. Does that make anywhere close to that, Doc?
That's thankful. That's helpful. Thankful. I'm going to now go to our audience. I have Jared Kerr, Vice President of the North American SAI Consortium, has a question. Go ahead, Jared.
Vice President, okay.
Thanks, Doctor. I appreciate your time. Great presentation. There's some engineering involved there that I thought was just phenomenal that I learned a little bit more about. I know about, amplitude and the waveform and wavelength and yada yada yada. But I hadn't thought about how altering that amplitude and the dampening of the sinusoidal wave, like the dampening of the impact of basically the energy we're sending through the skin, and altering it in a way where the body is going to naturally get used to the same one over and over and over again. I like the analogy of a song. I thought that was great. I'm stealing that, if that's all right with you.
Yeah, please, that's okay.
But
you have to come down. If you steal, you have to come down here for barbecue in Fort Worth sometime.
That's fair. I'm a fan of Texas, so in small doses.
Yeah.
No, but so I didn't know if you could speak any more, like if you've seen other. It sounds like, based on the examples that you gave, it sounds like there aren't any major studies out there with large numbers of people. I'm wondering if you've looked at if that particular technology, if you've re-engineered backward engineered, reverse engineered any other products that are out there in the market, some that recently hit the market. Honestly, there's some great stuff in electrical stimulation that is coming down the pipeline for us and for the world.
Right. So what I did was, seeing is believing, and my next phase is we've just got approval from, and I didn't want to give a shout out to my medical school, but I'm on staff over here at Texas Christian University Med School, and we've opened up a center of excellence to start trying to get objective data. So if you say you're influencing the autonomics, okay, what's that doing to the beat-to-beat variability? What's that doing to the tissue heat, which we assume is more blood flow? What's that doing to some other things? And it has really exploded. And again, I got into this field not directly. It was more about a necessity, and we do want to study that. And again, and I'm not married to Avazzia. I'm not even engaged. But certainly this has met my needs. And my next thing is the feedback of, I want to look at fields in a piece of acetate that we're doing. This is our first bit of research that looks at how the conductance can be mapped. And so we could map pain theoretically. Okay. And then how do we get better signals into the tissue, which I think is where you're alluding to. And there's a couple of different devices. And I put a little checklist in one of the slides, one of the first slides is, hey, is it alternating current? Well, no, it's direct current. Okay, well, you might not want to choose that. Is it enough volts? No, well, you might not want to choose that. Yeah, can it go at least an hour? Yeah, okay, good. Is it simple to turn on and off? Yeah, okay, good. And so that's kind of what, but as more things come along, send them to me. We still get mail. It takes us a while to get it through the stagecoach, but we still get it.
Great, great. Before I let you go and turn it over back over to Barry, there's a company called Parable Health that I met at I think it was PVA conference, and basically they take a picture of like a pressure sore and they're able to map that whole the different layers of the skin of the epidermis. So there's 5 different layers. Most people don't know that of the skin. So it makes sense to what you're saying that Avazzia's product that altering the waveform could actually penetrate all the different layers and heal at different magnitudes depending on the severity.
Absolutely.
Yeah.
Absolutely. Yes, sir.
Thanks a lot. That was a great question, Jared. I have another question from Jorge in a second. I'll take it. The one thing, Gabby, if you can, is put in the chat room how we can contact Avazzia and get more information, direction to the website and on the product, so that individuals here and beyond, just to give you guys a heads up that this webinar will be stored in our resources section, and the archive hits is actually quite significant. We'll get a lot of people that might come back to us and ask about this great presentation, but more importantly, how they can contact you and get back to you. So I just wanted to do that shout out there. If we can put that in the chat room, that would be great. Just the regular contact information for Avazzia. Jorge, you have a question. Go ahead.
Yes, thank you. Very nice talk. I have 2 questions. The first one is, according to what you present, it seems like this device acts on inflammation when people have spine cord injury. Do you know if it might have the same activity on people which spine cord injury have already gone through the inflammation process? People that probably have like 5 or 10 years with chronic pain. Do you think this device will still be useful for reduced pain or even provide mobility?
Right. So the few folks that have come in to the VA that I've seen, okay, I don't deal with the chronic folks that you do, but the more scarring and the more ischemia to the tissue, and that's any tissue, muscle, bone, joint, and especially nerve, it doesn't work as well. Absolutely not. And I think if I would have waited 4 days to come in and get all the permission slips and everything else for my friend who was at Walter Reed, it still helped to be in the Pentagon, and was able to get this device on him within 4 hours of his injury. And so, yeah, time is not always on your side, and it's much harder to deal with folks that are 10 years down the road than 10 hours. Yes, sir.
Okay, and my second question was about the case 2 from the Guillain-Barré patient.
Yes,
Do
sir.
you know if this person, besides the Avazzia treatment, they also got the regular plasma exchange?
I'm sorry, say one more time about the change, sir.
Oh, the patient with Guillain-Barré.
Right.
I know the regular treatment is to get plasma exchange to just
Right.
get new antibodies. Do you know if the person that went through the Avazzia treatment was also into this plasma exchange treatment, or they only receive Avazzia?
Absolutely. We got the plasmapheresis, they got the IgG, they got all that. And then we came in usually about anywhere between day 14 and day 30. And I haven't had, after 15 doses of IgG in that first 45 days, after that, I haven't seen that work at all. And I've seen the Avazzia still work many months later. And we've got now our study, we hope to publish that in about another month. We have 35 Guillain-Barré folks. We're in a big city, so we attract them throughout Texas. And everybody's gotten better, some more than others, obviously.
Okay, thank you.
Now, Doctor, you mentioned earlier on that this hasn't ended yet in terms of your studies and trying to
no, this is just
figure this.
Yeah, we're attracting more folks. We've got a foundation set up because this can anything can get expensive, especially when you're coming back and forth and traveling. We hope to minimize that. We've got some online classes. We're establishing some online telemedicine stuff. So we're looking at doing that. But the Center for Neuromuscular Health looks at the therapies and also the diagnostics, the objective data, which is really important for just about anybody, especially the VA.
And just to confirm that people that are interested in possibly being part of the studies or part of the Center of Excellence, they can find that information out through contacting Avazzia directly. Is that correct?
Absolutely, and we officially come on board on the 1st of October. So this timing is great. Thanks for the plug.
All right. Well, is there any more questions out there? This is your last chance to ask now. If not, we can then you direct that to them directly. But we have a question online from Krista. Any
Okay.
thoughts about about increasing degenerative changes? Any thoughts about chronic but increasingly degenerative changes at the injury site in terms of prevention? So using this as a preventative tool.
Wow. I haven't really had any proposals or thoughts down that road. And again, the problem again with statistics, because I hung out in the Pentagon, and you know, and if you prevented something, it never happened, and it's hard to get those studies going. However, what we think is that if we do any kind of regenerative therapies, which is PRP, exosomes, stem cells, whatever, which we're not doing yet, we think that we can actually get tissue to regenerate as well, and with some help with this, and maybe with lasers as well. We plan on doing a study here that starts right after the first of the year that uses all three.
Well, thank you for that. It sounds like there's lots to figure out still going forward, but you're getting some positive results in the early days, and we look forward to seeing how that can go forward in any way possible. We want to thank you and Avazzia, and especially a shout out to Avazzia in general. Your support really helps us share the message and provide the resources across North America, if not the world. And we're here to work with you in any way possible if you want. And thank you for giving us that information. Doctor, thank you so much for taking the time today. It was a great presentation. And we look forward to hearing more on the advances of Avazzia and their laser and the electrode treatment. Sounds great. So that's it for today, everybody. Again, this is how you can contact both the good doctor and Avazzia directly to find out more information on this great product. Take care and have a great day. Thank you.